the Department of Hematology Oncology, um, and I'm going to discuss implementing a bispecific T cell engager therapy or BiTE therapy in the solid tumor setting at our facility today. If we can go to the next slide. So right now, this BiTE therapy is approved in small cell lung cancer. So I'm going to start by giving an overview of small cell lung cancer. These cancers make up approximately 13% of lung cancers that are currently diagnosed. Small cell lung cancer is primarily caused by smoking. There are other causes, but that is something that if you see on a pathology report that it is a small cell lung cancer and the patient reports to you that they are a never smoker, it's always a good idea to double check with your pathologist and then talk with the patient about what kind of exposures they may have had if they had significant smoke exposure as well. Um, Small cell lung cancer is considered to be more aggressive than non-small cell lung cancer in most cases. In addition to the traditional T, N, and M staging that's used for lung cancer, we classify small cell as either limited stage or extensive stage disease. That limited stage is stage 1 through 3, and extensive stage is stage 4. Um, Current treatment for the extensive stage disease is primarily systemic therapy using a combination of chemotherapy and immunotherapy. You can also use other modalities like radiation for specific patients. So, if a patient responds really well to chemoimmunotherapy and you want to consolidate them with radiation, that's always a good reason or a good discussion with your radiation oncology friends. Um, Small cell lung cancers are typically very chemoresponsive. However, the rate of relapse is high, and the long-term response to immunotherapy is lower than what's seen in non-small cell lung cancers. So these are patients that we are very hopeful that they will respond to the immunotherapy as a single agent after we finish the chemotherapy, but we typically do have to be keeping a very close eye on things to determine if that is the case. Next slide, please. So this is just a slide detailing BiTE therapies. So the bispecific T cell engager therapies work by binding two target proteins on the surface of different cells, specifically a healthy immune cell, which is your T cell, and a different protein on the cancer cell, which is specific to the type of cancer. So they're considered a targeted therapy, and they are currently approved in ALL, which is a leukemia, multiple myeloma, lymphoma, and then in small cell lung cancer. So the reason why this is important for us is that our hematologic malignancy colleagues have experience with these bispecific T cell engager therapies that we on the solid tumor side may not have as much experience with. It's a little bit different than what we've been doing, where this has some similarities to the CAR T therapies that are used in or in those hematologic malignancies. So that's why I wanted to speak about it today. If we could go to the next slide, please. So tarlatamab is the therapy that's approved for small cell lung cancer. It is a bispecific T cell engager immunotherapy targeting CD3 and the delta-like ligand 3, so DLL3. And by binding to both the CD3 on the T cells and the DLL3 on the cancer cells, the therapy leads to T cell mediated death or lysis of the cancer cells. So this DLL3 is a protein that inhibits Notch signaling and is usually found inside the cell in normal cells, but is expressed on the surface of small cell lung cancer cells. Now, you don't necessarily have to check to see if your patient is actually expressing DLL3 from their tumor because the approval is not based on that. It is thought to believe that most small cell lung cancer patients would have this protein on their cancer. And then this is just an infograph that kind of goes into a little bit more detail about that process. We can go to the next slide, please. So tarlatamab was initially approved for use in the second line setting and beyond in small cell lung cancer patients on May 16th of 2024. That was based on the results of a phase 2 clinical trial, which was the Delphi 301 trial. So this was the trial that from December of 2021 to May of 2023 enrolled 222 patients. 176 patients were randomized to receive either 10 milligrams or a 100 milligram dose. And based on the results of the interim analysis, the 10 milligram dose was selected for parts 2 and 3 of the trial. Um, this was actually a trial that was open at our site at MBRCC, so that patients could participate. A 40% response rate was noted in patients receiving the 10 milligram dose, and a 32% response rate was noted in the patients receiving the 100 milligram dose. Of note, many of these patients had received 3 lines of treatment prior to the enrollment. So they were very, very treatment, or they had received many lines, like I said, and may have had various toxicities from those things. And they were patients who had been in the system for a long time, wherever they were seen. In more than half of the patients that responded, the duration of response was at least 6 months, which is pretty significant in the third line or fourth line of treatment for small cell lung cancer. That's not something that we very commonly see. Next slide, please. Um, so this is the approved dosing, and it is a step-up dosing process to try to help mitigate some of the side effects that can be seen. So the initial dose is 1 milligram IV on cycle 1, day 1. Then the patient receives 10 milligrams IV on days 1 or on days 8 and 15 of cycle 1. And then they're transitioned to 10 milligrams on days 1 and 15 of a 28-day cycle moving forward. Um, and then that continues until the patient has unacceptable toxicity or disease progression. So the patients must receive IV fluids for 4 hours following all doses in cycle 1 and must be monitored frequently with labs on cycle 1, days 2, 3, 9, and 10. So this is based on guidance from the package insert. And then patients come for vitals and ICE assessments on days 2 and 9 AM and PM, and days 3 and 10 in the AM. And I'll go into more detail about the ICE assessment on future slides. Next slide, please. Um, so the side effects of tarlatamab include cytokine release syndrome, or CRS. This is caused by the rapid release of cytokines into the bloodstream from immune cells that have been altered by immunotherapy. And the signs and symptoms of CRS include fever, nausea, rash, headache, elevated heart rate, decreased blood pressure, and shortness of breath on exertion. So some of these things can be things that we already see in our patients to a certain extent. So it's very important to have like a documented baseline, especially if the patient is someone who like chronically runs with a slightly low blood pressure, or if they're short of breath on because of their lung cancer diagnosis. It's very helpful if the patient is seen by someone who knows them or who has some context for what their condition was before they started the treatment. Um, the other big side effect that we worry about is called ICANS, which is immune effector cell associated neurotoxicity syndrome. This is a clinical and neuropsychiatric syndrome that can occur following administration of certain types of treatment, like this bispecific therapy. Um, it's tested using the ICE scoring system, which is a 10-point system. And the information about that is that we ask the patient to tell us what what month and year it is, the city that they are in, and the hospital. Their ability to name 3 objects, the ability to follow simple commands, ability to write a typical sentence. So we do ask that they write the same sentence each time, and then the ability to count backwards by 10 or by 100, or from 100 by 10. Next slide, please. So these are just some graphs on the side effect management. It goes into the grading system for the neurologic toxicity management. So basically tells you like if the patient has a grade 1, that's scored as an ICE score 7 to 9 with no depressed level of consciousness. So you should withhold that tarlatamab until the ICANS resolves and resume at the next scheduled dose. If they have a grade 2, that's an ICE score of 3 to 6, and or like the mild somnolence upon awaking to voice. So again, you're going to be holding that tarlatamab and resuming at the next scheduled dose. Manage with supportive care. Frequently, they do need IV steroids for this, which it can be repeated every 6 hours if it's Decadron, or every 12 hours. You can transition to the methylprednisolone. You're also monitoring for increased neurologic symptoms. Um, and then if this does happen, they do recommend that you monitor the patient for 22 to 24 hours following the next tarlatamab dose. Grade 3 would be an ICE score of 0 to 2, and or depressed level of consciousness, and or any clinical seizure activity, um, any or non-convulsive seizures on EEG. So this goes into more detail about when you would obviously withhold tarlatamab there as well. If there's no improvement to grade 1 within 7 days, or grade 3 toxicity recurs within 7 days, you permanently discontinue. There's a chance that the patient may need mechanically ventilated, and they should be cared for in the ICU. They receive IV steroids, and close monitoring for this. And then grade 4 is an ICE score of 0. They do recommend that you permanently discontinue the Tarla if this were to occur. ICU level of care, mechanical ventilation if needed, high dose steroids, and then very, very close monitoring. Um, and then the other graph on this goes into more detail about the CRS management. And with CRS, this is where if the patient develops a grade 2, you would consider giving tocilizumab to treat that. So that's a therapy that can be used to help with the side effects of this treatment. I won't go into specific details about each of the individual grades for cytokine release syndrome, but I do think that this is very helpful to use if you are ever treating a patient who develops these symptoms. Obviously, this would be being managed on the in the inpatient setting. Potentially, you could consider grade 1 management outpatient, but we do not do that at this time. Even grade 1 management, which is just a fever without hypotension or hypoxia, would require hospitalization at this point. Next slide, please. So this is our policy and procedure that we have implemented for the bispecific antibody. This is specific to tarlatamab. I just wanted you all to be aware that there is a very specified policy and procedure for what we're doing for this patient population. Next slide, please. Eligibility criteria for our patients, we want the patients to remain within 60 minutes of our facility, which is the Mary Bab Randolph Cancer Center, beginning with the initial dose and throughout all recommended monitoring periods. They must have a caregiver 24/7 throughout all step-up dosing and for at least 24 hours after initial treatment dose. And they must be capable of managing their care prior to initiation of therapy in the outpatient setting. So this is very important for us. We get a lot of referrals from this for this therapy from outside institutions. And when I say a lot, we've had several so far. Again, this is a relatively new therapy that we started giving in the fall of last year here in Morgantown. Um, so we're up to around 10 patients that have been treated. And we continue to accept referrals for this. We do have the family house as an option for patients who would be needing to stay closer, who are being referred from one of our regional sites or anywhere else in the state. Sometimes patients do opt for a hotel if that's more comfortable for them, and our social workers can help with potentially providing some assistance for that. Next slide, please. As I said, after the FDA approval in May, we submitted a request to our pharmacotherapeutics committee to add the medication to formulary. Part of that addition to formulary included developing that policy and procedure that was mentioned previously. And the first patient was treated in October of 2024. At the time of the original presentation, there were at least 5 patients who had been treated. Now I think we're closer to around 10, and specific clinical outcomes are still pending further review and follow-up imaging. So next cycle, please, or next slide, please. Um, these are just the references for the presentation. Um, if we keep going, I think I had a case that we could that I can present. Um, this was a 55-year-old patient who was found to have abnormal findings on a CT chest in December of 2022. Her PET scan in January of 2023 showed extensive disease. She was admitted with shortness of breath, underwent an EBUS, which is an endobronchial ultrasound, with FNA, which is a fine needle aspiration. On January 10th, the pathology was positive for malignant cells, high-grade neuroendocrine carcinoma, which is called small cell. She had extensive stage disease based on having bilateral disease. She was started on chemotherapy with carboplatin and etoposide, standard of care. Atezolizumab was added with cycle two. She initially had good response to the treatment and was transitioned to single agent immunotherapy. She underwent consolidation radiation, which with our radiation oncology colleagues in May and June of 2023. And she did quite well for a while. Unfortunately, her PET scan in February of 2024 showed progression, and she restarted carboplatin and etoposide since it had been greater than 6 months since she had received this therapy and she wasn't taken off for progression. She was still considered platinum sensitive, which is important in the small cell lung cancer patient population. Um, she completed 4 cycles of this, and her insurance denied further immunotherapy at that time. Unfortunately, her scan in October showed progression, and she underwent radiation to the area in the lung that was progressing, and restarted immunotherapy to see if there would be any additional benefit to this. Unfortunately, she did have progression of disease and was started on tarlatamab in February of this year. Next slide, please. And I think that that's it. So we're still, at the time of the original recording, we were awaiting response of how this patient respond, or we were awaiting imaging to determine how this patient responded, and any steps moving forward. But this is a therapy that we are very eager to see further information from studies come out. I've been told that there might be some information coming at ASCO this year that could be very interesting regarding this medication and other small cell lung cancer medications. So I will be very interested to see and hear more. And thank you all for your time.